This study is a continuation of prior work that we have done. I'll start a little bit of the reasons why we're doing this. We know that the risk of surgery for repeat mitral valve surgery is very high. The mortality is in the double digits. Even in contemporary practice, data from 1,000 patients on the STS now shows that the mortality is 11.1%, so high mortality. And mitral valve-in-valve has been used for several years, and retrospective data from VIVID registry, which is an international registry collecting early experience, and also a preliminary initial analysis from the TCT registry, the experience in the US, both show that the 30-day mortality was about 8%. So still a little lower than the surgical literature, but not that great. One common denominator in those two registries is that patients treated with mitral valve-in-valve were treated with transapical access, most of them. So the key question that I had in the mitral trial, which is not what I presented this time, but is the preliminary work, the mitral trial is the only prospective registry that is that has independent core labs, independent clinical event adjudication, FDA approved, and all that. I presented the one-year results this year at EuroPCR, and basically in that high-risk patient population treated with SAPIEN 3, mitral valve-in-valve, all 100% transeptal, the 30-day mortality was 3.3% in a patient population with an STS score of 10. So it was less than half of prior experience. So we knew all that, but what you can argue is, well, that's a highly selected patient population. It's a prospective trial that doesn't really represent true world experience. So what we did this time is look at real world experience of all transcatheter mitral valve-in-valve cases done in the United States and in the TVT registry, done with a SAPIEN 3 valve. And then we looked at the outcomes of patients treated with transeptal access versus transapical. So we took all of them who were treated between June and 2015 and last month, basically. There were more than 2,000 patients. And we excluded the valve in rings, the valve in mitral annular calcification, and few that were unspecified. And we took purely only the mitral valve-in-valves, with about 1,500, of which about 1,300 were done with transeptal access, which is a big change from the initial experience where most of those patients were treated with transapical. Now, most patients in the United States are treated with transeptal access, and there were about 200 transapical. And the key findings are that technical success was excellent for both groups, 97% in transeptal, 95% in transapical, and that was defined by MBAR criteria. Then we looked at mortality at 30 days. The primary effectiveness endpoint was all-cause mortality at 1 year, which I'll tell you in a moment. But just focusing on the 30-day, there's another key finding that the observed to expected ratio of the mortality was good for both groups. The 30-day mortality in transeptal was 5%, and the ST score for those patients was 11%. So the ratio was 0.45. And for transapical, the 30-day mortality was 8%, and the ST score was 11.7. So the ratio was also favorable in that arm, 0.6. So it was good for both. And when we looked at the endpoint at 1 year, for the first time ever in any retrospective review or prospective, we were able to identify difference in outcomes in all-cause mortality was lower in patients treated with transeptal access, 15.8% versus 21.7% in transapical. And we reached statistical significance with a p-value of 0.03. So we know now that transcatheter mitral valve-in-valve gives you better outcomes at 30 days than the outcomes that are seen in surgery. This is not randomized. This is just a registry with a lot of limitations like any other retrospective registry, but this is the best data we have that tells us about real-world experience in the United States. So good outcomes with both. They both are better than surgery. But when you look at those two, transeptal versus transapical, now there's evidence that transeptal is better for the patients. It was an independent predictor of lower mortality at 1 year in multivariate analysis. So I think now it's clear that the less invasive option is better for the patients. Well, I think that we now have data that supports that, in my opinion, this should be the standard of care for high surgical risk patients. We cannot extrapolate this to lower surgical risk patients, non-high risk. I don't want to say low risk because I don't know that there's such a thing as low risk redo mitral when we know the mortality is more than 11%. I don't know if there's such a low risk patient, but lower who does not meet criteria for high risk, that's already been evaluated in a prospective registry, which is Partner 3, mitral valve-in-valve, intermediate risk, which I'm one of the national co-PIs in that registry. So I would encourage all the sites to refer patients to this registry because we need that data to understand if it's also better for lower risk patients, because if so, then maybe the standard of care for all type of surgical patients if they have favorable anatomy. So there may be some patients who do not have favorable anatomy, maybe high risk of LVOT obstruction, or for other reasons for which it would be better to do surgery. But my prediction would be that perhaps maybe for lower risk patients, this is also a better option, and we will find that in that registry.